Pathoplastic drugs, these are the drugs that are most commonly used for the treatment of hypertension, and they have two major divisions: the alpha blockers and the beta blockers. In the alpha blockers, we use alpha 1 selective blockers, and this class contains three drugs: prazosin, trazodone, doxazocin. These drugs, they produces most of their antihypertensive effect by selectively blocking the alpha 1 receptors in the arterioles and venules. What actually happens is that the alpha receptors, they are present in the arterioles and the venules, and whenever these receptors are activated, the resultant phenomena is vasoconstriction. So this vasoconstriction, it increases the overall peripheral vascular resistance, and as a result there is a maintenance or there is an increase in the blood pressure. What we do with the alpha blockers is that we block these receptors, and when these receptors are blocked, the resultant effect is vasodilation. Now, as a result of vasodilation, the vascular resistance is decreased, so the SVR is decreased. So as we know that blood pressure, it is the product of cardiac output into systemic vascular resistance. So when the systemic vascular resistance is decreased, as a result, the blood pressure is also decreased. So this is how they mediate their antihypertensive effect. We use specifically alpha 1 selective blockers for the treatment of hypertension, because the non-selective alpha blockers, they actually cause an increase in the sympathetic outflow, which is a reflex activation. So we do not use non-selective alpha blockers for the treatment of hypertension, except in certain situations such as in pheochromocytoma or in adrenal tumors. Apart from that, the alpha 1 blockers, they are used to treat hypertension. However, they're not used as a single agent for the treatment of hypertension, and they're often used in combination with a diuretic or a beta blocker. However, these drugs, they have a special advantage in the setting of bladder obstruction and hyperplasia, because the alpha 1 receptors are also present in the bladder and the prostate. So in the men who have concurrent hypertension and benign prostate hyperplasia, alpha 1 blockers, they are the drug of choice in those situations. Now these drugs are available in the oral formulations, and they have prazosin. It has the most short half-life as compared to all the other members of this class. The trazodone, it has an intermediate half-life of around 12 hours, whereas doxazocin, it is the longest acting and it has a half-life of around 24 hours. So it is given once daily, and they may cause little postural hypertension. So we start with a very short first dose, and the first dose, it has to be administered at the bedtime in order to reduce the orthostatic hypotension that is commonly seen with these drugs. The toxicity or the adverse effects of these drugs includes some central or side effects, which includes headache, dizziness, palpitations, and lassitude, which is a feeling of a general unwellness. It also, some patients also develop a positive test for ANF, which is anti-nuclear factor, but this is not associated with the rheumatic fever. The alpha blockers, they do not adversely, however, they have a beneficial effect in the plasma lipid profiles, and prazosin, it has been observed to have a beneficial effect on the lipid profile. So this is a desirable side effect that is seen with these drugs. The next class is the beta blockers, and beta blockers are the most widely used drugs for the treatment of the hypertension. And among the beta blockers, the first drug or the prototype of the drug is propranolol. Propranolol is a non-selective beta blocker. It acts on beta 1 as well as the beta 2 receptors. these receptors are present in the heart, and what actually propranolol does is that it binds with these receptor and it reduces the cardiac output, and this is how it has a antihypertensive effect. These are the drugs, they are very effective in the treatment of hypertension as well as ischemic heart disease. Propranolol, it has been largely replaced by cardioselective beta blockers such as metoprolol and atenolol. However, they are all of these beta blockers. They are very useful in lowering the blood pressure in mild to moderate hypertension. They are also used as a sole agent in the treatment of hypertension. They do not cause any reflex tachycardia that we have already seen with the alpha blockers, and the toxic effect profile is also tolerable. It's not that much. So the effect, overall effect, or the mechanism is that they will reduce the cardiac output. The beta 1 receptors, they are present in the heart, and they are usually responsible for a positive inotropic and positive chronotropic effect, which means that the heart rate is increased and the contractility of heart is increased. So when these receptors are inhibited by beta blockers, we see a decrease in the heart rate and decrease in the contractility, which causes a decrease in the cardiac output. So if we recall the formula of blood pressure, it is cardiac output into peripheral vascular resistance. So here we are decreasing the cardiac output, which in turn causes a decrease in the blood pressure, and this is how the blood pressure is just decreased. Beta blockers, they also decreases the peripheral vascular resistance to various degrees, depending on the agonist or partial agonist or cardioselectivity activities. It also inhibits the stimulation of renin in the kidneys. The beta 1 receptors, they are also present in the kidneys, and in the kidneys when they basically promote the production of renin. But when we inhibit the receptors with beta blockers, there is a decreased production of renin, and this is how it also depression of the renin angiotensin aldosterone system. It also plays an important role in decreasing the peripheral vascular resistance as well as the sympathetic vasoconstrictive nerve activity. So in mild to moderate hypertension, propranolol, it produces a significant reduction in blood pressure without any postural hypertension, which is a very common phenomena that is seen with the alpha blockers. So if we want to monitor the therapy, we can see that the patients who are taking propranolol, they will have a resting bradycardia, and there will be a reduction in heart rate during exercise. So these are the indicators of the propranolol beta blocking effects. So propranolol, it can be administered. It has a short half-life, so it can be administered twice daily. And there are also some formulations available that are slow release, and they are once daily preparations. The toxicity, as far as the toxicity of propranolol is concerned, the blockade of cardiac, vascular, or bronchial beta receptors and is accompanied with the pharmacological effect of propranolol. So this is not a drug of choice in the patients who have asthma and on the patients who have peripheral vascular diseases or diabetes. When beta blockers are discontinued after regular use, patients may experience withdrawal symptoms as well. Symptoms that are seen with the beta blockers are usually nervousness, angina. There is an increased intensity of angina, the blood pressure is increased, and tachycardia. So therefore, the beta blockers, they should never be discontinued abruptly. We have some cardioselective beta blockers as well. On the metoprolol and atenolol, these are cardioselective, which means that they will act on the beta 1 receptors only. They will not interact with the beta 2 receptors, and they are the most widely used beta blockers that are used in the treatment of hypertension, both metoprolol and atenolol. So they are less potent than propranolol in blocking beta 2 receptors. So they can be used in the treatment of in the patients who have asthma, diabetes, or peripheral vascular disease, which was a problem with the propranolol. So these drugs, they causes less bronchoconstriction in the asthma patient. So we can use these drugs in the setting of asthma. And these drugs, they are metabolized in the liver and they undergo extensive first pass metabolism. The metoprolol has a short half life of around 4 to 6 hours, and same as the case with atenolol, it has a half life of 6 hours. Both these drugs are metabolized in the liver. Sustained release preparations are also effective in reducing the mortality with heart failure. And atenolol, it is less efficacious than metoprolol in preventing the complications of hypertension, but both of these drugs, they can be used. The other class of drugs, which is nodalol and carteolol, these are again non-selective beta blockers. They are not very commonly used in the practice, and they're not metabolized and excreted to a considerable extent in the urine. Betoxolol and bisoprolol, these are beta 1 selective, and among these, bisoprolol is most widely used as compared to the betoxolol. So nodalol, it is usually begin at the dose of 40 milligram, and betoxolol, it is given in the dose of 10 milligram. Increase in dosage to obtain a satisfactory therapeutic effect should take place no more than every 4 to 5 days. The third class, which contains pindolol, acebutolol, penbutolol, all these drugs are partial agonist as well, which means that they will interact with the receptor and produces a very little agonist effect as well. And they have intrinsic sympathomimetic activity. They will lower the blood pressure by decreasing the peripheral vascular resistance, and they also depresses and decreases the cardiac output, or they do not depress the cardiac output as the non-selective or selective antagonists, because they have a little very intrinsic small sympathomimetic activity as well. So these drugs, they are particularly beneficial for the patients who have arrhythmias or who have peripheral vascular diseases. Now, the next class is labetalol, carvedilol, nebivolol. All these are beta blockers. However, they also have vasodilating effects. That is why they are placed in a different group. So labetalol, it is available in the form of a isomers. It has 4 isomers, and the formulation that is available in the market is a racemic mixture of all these isomers. Two of these isomers, they are relatively inactive. One isomer, which is the SR isomer, it is a very potent alpha blocker, and the other isomer, which is the RR isomer, it is a very potent beta blocker. Labetalol is a drug of choice in the management of hypertensive emergencies. It is used as a continuous infusion in the treatment of hypertensive emergencies. So the blood pressure, that is lowered by the reduction of SVR. It decreases the systemic vascular resistance, and it also has an effect on the cardiac output and heart rate, but it is not very significant because it has a combined alpha as well as beta blocking activity. The beta role is also useful in the treatment of hypertension of pheochromocytoma, which is a adrenal tumor, and it is also used in the treatment of hypertensive emergencies. Now, carvedilol, it is again a non-selective beta blocker, and it is also administered as a it is also formulated as a racemic mixture, and both of the isomers, the S and the R, they have approximately equal alpha blocking potency. The half-life is around 7 to 10 hours, and it is given usually twice daily. It reduces the mortality in patients with heart failure and hypertension. It is a very important drug. Nebivolol is a beta 1 selective drug, and the unique feature of this drug is that it causes vasodilation, and this vasodilation is mediated by the secretion of NO, which is nitric oxide, and nitric oxide is a very potent vasodilator. So nebivolol, it causes the increased secretion of nitric oxide, and as a result there is a decrease in the systemic vascular resistance. So the antihypertensive effect of these drugs, it is mediated by decrease in the systemic vascular resistance. The half-life of nebivolol is around 10 to 12 hours, and the drug, it can be given once daily. The efficacy of nebivolol is similar to that of the other antihypertensive drugs, but several studies report fewer adverse effects. The last drug of this class that we need to discuss is esmolol. And the unique feature about this drug is that it has the shortest half-life among all the beta blockers. It is beta 1 selective, which means it can be given in the patients who have asthma or who have peripheral vascular disease or diabetes. It has a very short half-life of around 9 to 10 minutes. So this is why it is used in the perioperative procedures, and it is given as a IV infusion. The antihypertensive effect, it is rapidly reversed after the infusion is discontinued. It is usually administered as a loading dose and which is followed by a continuous infusion. It is used for the management of intraoperative and paraoperative hypertension. And as soon as the drug is discontinued, the effect is reversed because it has a very short half-life, and it is sometimes used for the hypertensive emergencies. However, whenever the hypertension is associated with tachycardia, or when there is a concern about toxicity or such as aggravation of severe heart failure, in which case a drug with a short duration of action that can be discontinued quickly is advantageous. In those conditions, we use the esmolol. So this was about the beta blockers that are used in the treatment of hypertension.